Thanks to Dr. Pratt and Dr. Williams for inviting me to speak here today. I'm not a pediatric surgeon. I am an adult bariatric surgeon, but I direct an MBSA-equipped comprehensive center with adolescent qualifications, so I do operate on adolescents. There we go. Now, SAGES gave us instructions about the disclosures. They said we were supposed to hold the disclosure slide up for 7 seconds. So I did find some 7-second challenges online. You know, maybe the best one is name 3 fruits that start with B and you can't use blue or black. That's about 7 seconds. Okay. So there is some good news, which is that multiple publications show that, to the best of our knowledge, this is a really safe thing to do with kids. There have been fewer than 6 deaths reported at the time of this publication after bariatric surgery in adolescents, and none of them were actually considered to be a post-procedure complication-related death. There's the ones that we have are this one by Dr. Mikowski, who had a 19-year-old kid with a BMI of 65 and dilated cardiomyopathy, really high-risk patient, coded and died in PACU, and they did not find anything on autopsy, so the suspicion is that it was some sort of arrhythmia, just like might happen in an adult. But these things are still terrible, and we hate it when it happens, and so at least we talk about it. But is there data on procedure choice in kids? Well, this article tells us that, well, actually, no, there is no high-quality data. We need some well-designed trials to compare the outcomes of these various procedures in adolescents. And there is something called the Teen Bypass Equipoise Sleeve Trial, or Teen BEST, which is going to be accruing patients. It's expected to complete accrual in 2027. And they hope to compare bypass and sleeve side by side with 116 patients in each arm, which still isn't a lot, but it'll probably be more than what we currently have. So what is the best procedure? The data that we have comes from the 2018 ASMBS Pediatric Metabolic and Bariatric Surgery Guidelines, where they looked at the 4 big procedures that we have: band, bypass, sleeve, and switch. And we'll start with the band. So Paulus did a pretty good-sized meta-analysis. They looked at 18 studies with over 600 patients, saw no deaths. There was only about a 10% complication rate overall, and GI complaints, whatever that is, was also about 10%. So interestingly, even though the FDA-approved trial was completed in 2013, those data have not yet been published. So the important thing to know is that if you're going to use bands on patients under 18, you should only do it in the setting of a clinical trial. Don't just put it in because you have it on the shelf. Looking at bypass, first of all, the Teen Lab study published in 2016, they had about 242 patients. There was good BMI loss, reinterventions, which is operations and other things like that, about 19%. Overall, 30-day complications, 9%, and not along with the significant weight loss, they had significant improvement in their comorbidities and in their quality of life. So again, Paulus, his meta-analysis, he broke it up. 6 of the studies looked specifically at BMI loss. 9 of them looked at complications. Again, reintervention rate about 17%, and then a 30-day complication rate of about 11%. They did comment that gastric bypass in children who are smoking or living with smokers is probably a problem. In kids who have problems with medication compliance, there's a reasonable chance they're not going to want to take their supplements, so that's a problem. But as in adults, it is a really good operation for children who are dealing with GERD. All right, now what about the BPD plus or minus DS versus, or SADI? This article in Obesity Surgery from 2017 was basically a multi-society expert panel assessment. They did a Delphi method. They had 60 experts who comprised 9 national societies, and their bottom line was, first of all, the regular Scopinaro BPD should be abandoned in adolescence. It leads to excessive morbidity and very severe nutritional deficiencies. There aren't, I think, any programs in the United States that are offering the BPD. But the DS and the SADI, they may be reasonable alternatives, but more studies are needed, just like more studies are needed in adults. So we don't know the answer to that. So that leads us to sleeve gastrectomy. Teen labs compared to the Paulus meta-analysis showed very similar improvement in weight loss, very low 30-day complication rates, and again, a reasonably low reintervention rate in all patients. So the bottom line of that is that the sleeve does have a slightly lower comorbidity resolution rate compared to the bypass. However, there's very similar weight loss between the two of them and a significant lower complication rate with the sleeve. So the sleeve is now the most recommended operation in the adolescent population. So this is what most people are doing for most patients, and it's based on what little data we have. So that's it. Thank you.